another one maybe the next few weeks, maybe another one next month. We'll see. Hopefully soon.
Mustafa, if you don't mind.
Yeah.
When we frequently discuss about the FAQs, is it the frequently asked questions that is on the, okay, fine.
Yes.
And is it a PDF form or just the questions that come up when you click on that particular link?
It's a PDF. It's a PDF form. But that's quite old, by the way. That's like 2012 or something like that. So it's a bit old. It's not new, but it's very relevant still. But things have changed slightly. I can see Prashob there. Hi, Prashob. Hi, welcome.
Hello. Hi, Mustafa.
Thanks for joining us. I'm recording at the moment, so hopefully people can watch it later if they wish. I usually upload it on YouTube, so you can watch it as much as you want. So Prashob doesn't need any introductions. He's very famous on the group. He's been very helpful. I've been seeing what he's been doing on the group. I'm really, really impressed. He's a consultant in Northern Care Alliance. That's Greater Manchester. Is that correct?
Yes.
I know a previous colleague who worked there. And he does cornea, so well done. And I'm sure everyone knows that he's just got his application accepted last week, correct?
Yeah, 28th of Feb.
Yeah. So well done. I'm sure you're very relieved. Yeah.
Yeah.
So it's a long journey, I know. So I usually start off with asking you, when did you start your journey? What sort of what's your experience in the whole thing? So you can just give us an introduction of what you've done.
Yeah, so I came to the UK in the November of 22. I was working as a consultant in India for quite a long time, since 2016. Well, I had to come to the UK basically because my wife decided to move here, and in that decision was in, I think, early 22. And then it was like a sudden rush of blood. You had to get registration, and you somehow. I mean, I had a 5-year-old daughter. I mean, she's 6 years old now, and she was quite young at that time. Yeah. So I can't leave my wife and my daughter alone. And of course, in the UK, it's difficult to have a family life with just one person earning. So I couldn't be a husband either. So it was kind of an emergency situation where I had to find out some way to get GMC registration. I had nothing, no exams, and I just had my Indian degrees and my experience. That's all. Mm-hmm. So I just jumped on the whenever I got a chance to write the exam, I wrote it. So I started with the FRC of part 1. That was in February 22. And then I wrote, then because FRCS Glasgow is also accepted as something to get GMC registration. So the next exam that came my way was FRCS Glasgow Part 2, because you're exempted from Part 1.
Yeah.
So I wrote that, and then I just kept writing whatever exam was available, So finally got to finish with FRCS all parts in, I think, August of 22, and then I could apply for GMC registration. So that was a relief.
Good.
Yeah, I did because they had started conducting FRC of the RC of had started conducting exams in India at that time, in that very year. So I could write all the parts in India, except for the refraction certificate, which I failed in the first attempt.
Yeah, I did the same.
Yeah. So
you're not on your own.
It was really funny. The reason I failed was all down to the iPad.
All right. Yes.
I really did not take that into the consideration. I did all my practice. Everything was perfect, but I did not figure that. I mean, I did not factor the iPad into my situation.
You need to train on the iPad. You need to train
I was just writing on a piece of paper, and then I suddenly realized I had to put this onto the iPad. So basically, I ran out of time. I lost out by like a few marks. Right.
Yeah.
It was disappointing, but then I found out the tool on the RCF website, which lets you simulate the iPad. So I started practicing on that. I wrote the very next exam in Glasgow. So I got through the next exam in Glasgow.
Good.
and finally finished all my parts in October 22.
And during that time, were you getting your evidence as well, or how did you manage both together?
So some of the evidence, I mean, I had some plans, some rough plans to come to the UK, even as early as 2017, 16.
Yeah.
So I didn't know much about it, but I just went through the website of RCOFT, and I was just collecting whatever things I was doing. I was not doing much work other than cornea refractive. Yeah. So in that area, whatever I was doing, I was collecting some evidence, but it was not much at all. It was not much substantive, nothing substantive at all.
Yeah,
just a little bit of bits and pieces here and there, because I was not really sure I was going to come to the UK.
Right, but you did have some evidence from India.
Yes, it was useful though. For some hard to get competencies, it was pretty useful.
Yes.
I mean, for those who are watching who are not in the UK yet and are planning to come, this don't take your practice lightly, because there are a lot of things outside the UK. I mean, the volume is humongous out in India. I mean, the number of patients that you see in a week in the UK, you see in a single day.
Yes.
Maybe even half a day. So there are lots of things you can bring to the UK, the evidence, if it's recorded in the proper form. Yeah. So don't be lazy. If you are actually planning to come, you should start right now, even if you don't have any exams, nothing, just start collecting your evidence wherever you're working.
But the question is to you, do you think if someone is not planning to come anytime soon to the UK, would they accept all of your evidence from overseas? That's the big question.
So that's the thing. That's a big question. I mean, you should have some kind of a rough plan. It's 5 years. They do accept some evidence up to 7 years, but the majority of the evidence has to be within 5 years. Maybe one or two pieces of evidence that may be in the 7-year bracket, but the majority should be within the last 5 years. So you just keep that in mind
yes.
when you're doing that.
Yeah.
Probably if you're thinking about CESR, you are thinking in 5-year time frames. I mean, you're not. I don't know if people think in 10-year time frames. I mean,
yeah,
it's beyond. Yeah. I mean, I don't know what I'll do in 10 years from now.
Sure. Yeah. Sure. And again, most people, lots of seniors here in the group, they've had lots of evidence. Let's say they've done 50 squints in the past, and then they just want to add more, maybe 5, 10 recent. Again, the question is, would that be, included as maintenance of skills or not? That's again another question I get asked a lot. What do you think about that?
Well, that's really. I mean, there are a lot of gray areas in the SSG and how CESR is conducted. It's a lottery, really. It's a lottery of the assessor that you get. Personally, if I was the assessor, I would accept it.
Yes, that's the thing. So it depends on the assessor, because people always say, "Oh, this is not mentioned in the in the SSG. This is mentioned. This is not mentioned." It's not just SSG. It's assessing your application as a whole. So and there is luck as well. My assessors were very nice and it went smoothly. Others have struggled with very tough assessors. So there is luck in it as well.
Yes, absolutely. So I mean, really small things like when I listen to some of the other candidates talk, things like the laser safety certificate. I mean, if I was the assessor, I wouldn't be too hung up on it. If the person is already doing lasers,
yes,
obviously they know about the laser safety.
Yeah,
I wouldn't be really hung up on certificates. But then if you want to go by the letter of the law and not the spirit of the law, you can actually tick the boxes. Say, yeah, no, you didn't do that, so you can't give you.
Yeah, I understand.
And then the problem with CESR is portfolio pathway is if you submit the evidence and it's not up to scratch. I mean, your assessor thinks it's not up to scratch, then you're behind by another several months. That's the most frustrating thing. Even if it's just one small thing, you are again pushed back by so many months.
Yeah.
So when I submitted that, I tried to make sure that I actually over submitted by quite a lot. So you
over submitted evidence.
Yeah, I was paranoid and.
Yes, I had the same.
Much of things in many areas. But then, a lot of things is down to luck. But nowadays, I would like to believe that things have become easier and there are assessors are taking it more easy.
Yeah.
And I hope more CESR candidates apply for becoming assessors.
I hope so too, because they are struggling. But Suita is doing a very good job. She's pushing a lot with the GMC and the college. So I
Yeah.
think things are going in the right way, not the other
Yeah.
way around. So I think that will help. And how about again? Let me again ask you something very simple. So you're just trying to get a few questions in my mind. So the evidence, yeah. So let's say evidence of your daily practice. Did you submit logbooks? Did you submit patient letters? What did you do?
So in this regard, I got evidence from people who submitted before November 23 and after November 23. So I say November 23 because that's the day, that November 30th was the day when CESR became portfolio pathway, and the whole thing changed quite a bit, where you could submit a lot of alternative evidence for the so-called green outcomes.
Yeah.
So that's I did submit a lot of evidence which the older candidates recommended. So I was speaking to all sorts of people. I know that I was speaking to you quite a lot as well. You disturbed you quite a lot. I think it's important to talk to all sorts of people. I mean, whenever I used to speak to the older CESR candidates, they would tell me that a lot more stricter evidence is required.
Yes.
Obviously, it's not their fault. It's that they are used to their sort of the SSG, their style of SSG.
Yeah.
They're not used to the post November 23 pathway. So I was collecting. I mean, I think my application would have gone through even if evaluated in the old pathway.
Yes.
More or less.
Yeah.
Because I was paranoid and I wanted the application to be watertight. So I was taking their evidence also into account.
Right. Yeah.
So I was collecting a lot of evidence of DOPS and CBDs and stuff which was mentioned in the older SSG, as advised by the older candidates.
Yeah.
And I also submitted some few outcomes when it became very clear that after I attended the training day, it became very clear that they would accept other evidence also. Then some of the outcomes I did not bother, going for CBDs.
Again, for those who are not really following, so what he's mentioning is that there was an old SSG and then there is a new one, and then there's a new portfolio pathway. That's a bit different. Yeah. So, and the new SSG is slightly more flexible. Yeah. I'm sure everyone has seen that Excel file with the green and red sort of things according to specialty. Things have changed. Like, for example, a tab. You don't need 2 tabs now. You maybe want to do one, maybe another one, sort of a CBD or whatever. So things have changed a bit. So
that tab is a good example. So I already did one tab as per the advice of an older candidate, and then I saw that in the new SSG the tab was not really that strict, and I talked to the assessors and I talked to the CESR leads on the training day, and then I did not run after another tab.
Yes.
What I did was I did a tab in a wet lab setting, and I also did a CBD where I requested a tab.
Right.
So one was a real tab, the other was on a wet lab, and the third one was a CBD. So in fact, even 2 CBDs would have sufficed in the new SSD.
I'm not. They haven't removed it in the new portfolio pathway, have they? It's still required.
It's still required. It's still required, as in you don't have to do a tab. It is the wordings are as per the portfolio pathway SSG for the old curriculum. For the 2016 curriculum, the wordings are the ideal thing to submit are 2 OSATs or a tab.
Yeah.
If you can't do that, you can even submit 2 CBDs where you have actually seen a patient and requested a tab.
Right.
They also accept the doing a tab in a wet lab setting.
Yes. So that's one of the examples that has become a bit more flexible. Again, the other thing is the enucleation. Again, I'm not sure how long will it stay there. It's not needed, so some things you don't need to do as a general ophthalmologist. You can always refer to your colleague. So some things are a bit weird. Another example is the IV cannulation. So again, I've submitted one and then done another online course and it works. So some things are not that important. But again, that will depend on your application. That will depend on the assessor. So people take it sort of, oh, he's mentioned this before, so was he accepted or not me? Maybe your application is weaker. Maybe you haven't focused much on other stuff. So it's an assessment as a whole.
So probably if everything else checks out and maybe you're not done venous cannulation, I think most SSS would just overlook that. Most SSS, I can't speak for all.
Right.
But most people would just overlook a really tiny thing. But if you're deficient in a couple of other areas, like you haven't done enough squints, you have not done enough cataracts, then it's going to be a tricky one.
Yes. And how about, I guess, let's again talk about the very important question now these days is should I apply through the old one or the new one? Yeah. So for someone, because I always say, if you've done your exam and you've done most of your cataracts, then definitely apply through the old one. Because, we've got experience in it and we all are aware of it. And even the college has got lots of experience, so they can help. So what's your advice? I mean, would you advise people to wait to apply through the new one? What do you think?
No, absolutely not. If you can submit a substantial amount of evidence before July 26, you should submit in the 2016 curriculum. That would be my advice.
And why is that? What do you think?
As things stand, we know Shweta is working on it, and a lot of us are supporting her.
Yes.
But as things stand, it will be ideal if you apply for before July 26 in the 2016 curriculum, because in the new curriculum, as Mustafa said, there are a lot of things that are unknown. There won't be many people who can give you advice. I think there will be no people actually. I don't think.
No one submitted through it yet, so that we don't know.
So you won't have any advice of an experience or how to go through that pathway. And of course, there's a huge red flag of the number of cataracts that we all been talking about.
Yes.
I personally feel it's discriminatory, but then it has to be discussed with the college and other stakeholders. 350 cataracts for level 3 and 800 for level 4, when no cataracts are mentioned for trainees, doesn't seem that good to me.
So let me pause right there again. In defense of the college, let's talk about the college percentage. So let's say a trainee, who is an ST 6 or 7, and they've done only 200 cataracts, which is possible, or 300 cataracts. Would that trainee be able to get a corneal consultant post? Definitely not. So still the trainee, yes, it's not in paper that they don't need that number, but practically speaking, they won't be accepted as a consultant in that surgical specialty without enough number of cataracts. So let's agree, all of us, that to become confident in cataracts, you need at least, let's say 500 at least. And again, a good number of complex cases and complex cataracts. So that's in their defense. 800 is, I think, too much. But you wouldn't expect a trainee to pass their training and convince their supervisor that I can finish my training with only like 300 or 400. That's not going to happen. What do you think?
Now let's live in the real world. I mean, I know the curriculum was designed so that they can eliminate fellowships.
Yes.
But in the real world, I really don't know. If I was sitting on an interview panel and there's a candidate who's done cornea and cataracts, I don't care how many numbers he or she has done.
Yes.
She has just passed, just got through CCT. I would be hesitant to take that candidate in unless they have a proper fellowship. Yeah. So I mean, most of the consultants I speak to, they say the same. I mean, many have done even 2 fellowships.
Yes.
But a fellowship is not the same in every institution. It's not the same as I'm doing a fellowship here. The fellowship in India is not the same as a fellowship in the UK.
Sure.
I mean, I've done a fellowship in India, so I know that it's much more intense and much more concentrated, where you get a huge number of cases in a short period of time. It's not the same in the UK. So many people end up doing more than one fellowship.
Yeah.
So regarding that, I don't know if anybody would really get a subspecialty, but they would definitely get a general ophthalmologist post.
Yeah.
But I don't know if somebody can make a cornea consultant just based on passing their CCT with level 4 cornea outcomes. I mean, maybe in some big institutions, maybe if they did it from Moorfields or something, you might accept. But generally, I would imagine people would require some amount of subspecialty experience after their CCT.
Yes. I agree. Especially cornea, VR, glaucoma, which are very, very surgical. You need to add another fellowship. It wouldn't work. And I agree with you that the number is not that enough. You need different experience.
I think it's not just about numbers. It's not just about numbers. And it's not just about surgery. Cornea is not just about corneal transplants.
Exactly.
It's about, you need experience of seeing patients.
Yes.
So it's again, I've seen candidates who've done like 200 cataracts who are super good, who are excellent at surgery. And
Yes.
I've seen people who have done more than 1,000, 2,000, 3,000 veterans really. And, you know,
They're not great.
you would not ask your relatives to get operated by them. So
Right.
it's not just about numbers. Finally, I personally believe that it's up to the trust and the people who are around the person to decide whether that person is competent to do a particular thing.
Yes.
Even if they have all the degrees and all the specialties and everything, if they're not actually in the real world not competent, they wouldn't get the job. They wouldn't be staying in the job for too long.
Exactly. That's what people are not sort of convinced. So getting on this register is something, and being actually competent is something else.
Yeah.
It's all an exercise. Okay, you'll notice very soon that it's not just about you being as a good doctor now. You know, I think most of your training that you're going to use in this consultant job is in the fellowship, not in your actual 6-7 years of training. You know, so it's just filling the numbers and ticking the boxes, but actually your training will be in your fellowship. That's why I don't think that the new curriculum has change things much. You know, still people will finish off and go out, you know, and look for different fellowships. So the training is still the same. It hasn't changed. And that's what's if we are not succeeding in changing the numbers for the new portfolio pathway, what's going to happen is that people will have to choose two non-surgical SIAs, like
Absolutely.
emergency and medical retina or something, and then they're going to have to spend another year or two doing another fellowship in their chosen surgical specialty of their dreams. You know, so yeah.
So that thing is there. I mean, because CESR candidates are varied. There are various types of CESR candidates. I mean, portfolio pathway candidates. There are those who have a substantial experience and they just don't. They just need to tick the boxes. And there are other people who are just in the initial period of their career. They also need training. And they also need to tick the boxes. So the way you approach is different in different cases. In my case, I already had a lot of experience. It was mostly case of ticking boxes, but also I could kind of refresh my memory and improve my skills in this other subspecialties which I was not doing quite a lot when I was doing the CESR pathway.
Yes, I usually advise people who are very young to start soon, because that's actually when you learn. You know, yes, you're ticking the boxes, but actually you're learning as well. Unlike more seniors who've actually done everything in the past, and they just need to do the paperwork again and do the vision, CRS form again, or remove a corneal suture or whatever. So that's a struggle. And the problem is that as you go older, I'm sure everyone will agree, you've got other responsibilities. It's not easy. It's not easy at all.
Yeah, that is a big issue actually. So as you grow older, as you're more into your career, there are different things that are. One is your family. You have family out, commitments. You can't just go on. I mean, you already spent typically in India to become a consultant. You would probably spend how many years? I at least spent 15 years of my life. So that you already invested so much time, and people would think around you, your family would think that now you're going to settle down and take care of the family and be a family guy. And then you go again and tell them that you're running after these things. Yes. It is very stressful, not just for you. You don't not only need a supportive trust, you also need a supportive family for this. Plus the attitudes in your mind. I mean, when you have been leading a department, when you are a senior consultant, and you suddenly have to step down quite a lot of steps.
Yes.
To request other consultants to sign you off for things that you've been doing like daily for years.
Yes. Sometimes you're asking someone. Sometimes you're asking someone who's more junior than you.
Junior than. So you have to let your ego take a back seat and step down a little.
Yes. Yeah.
Humble yourself.
Someone again asked me, is actually CESR worth it? Do you think for someone, let's say someone who's very senior in their, I don't know, in their 50s or whatever, they're a specialist, is it worth to go through all of that hassle just to become a consultant? What do you think?
Well, it really depends on your what your outlook is. If you want to lead a department, if you want to, if you are a go-getter, or if you want to do things your way, then you need to become a substantive consultant. Otherwise, you don't get, in the NHS at least, you don't get those privileges unless you are a substantive consultant. You will always be treated different, no matter how senior you are. It doesn't matter if you start as a specialty doctor, go to associate specialist, and maybe you become a specialist. Even then, you're always, it's been my experience that it's a slightly different treatment that you get. But if you're not of that mindset, I know a lot of people who are not of that mindset. There is no right or wrong in this. I mean, I respect Shweta quite a lot. I mean, she's one of the most brilliant women that I've met. I've been in touch with her quite a lot. And she's very happy with, she actually left training to be
she told me,
doctor. And she's very happy in her space. It really depends from person to person. So there is no one blanket answer whether it's worth it or not. But mind you, it is not stress-free. It is extremely stressful. At least in my case, it was. It is extremely stressful. Not just the application, the period after the application, the period waiting for the results, chasing the things up. It's not easy. I mean, if there was an alternative way, I would say take that. If they reopened the ST3 training, I would even say take that. But if you want to become a consultant and you have overqualified, you can't go for training, there's no other way. This is the only way. Go for it. I mean, you will have to bite down on a few things and then start doing it. That's the only way. And if that's your attitude.
Yeah, and I'm sure it's the only way for private practice as well, correct? So as a locum or a specialist, you won't have that chance.
Well, it's not exactly. I mean, I came here into the UK into private practice. If you want to believe, I didn't come into the NHS. So I joined a refractive surgery chain initially. I got recruited directly from India. So theoretically, it's a misconception that in private practice you need to be on the specialist register to do private practice. That's not true. You can do private practice even if you're not on the specialist register, provided the people who are employing you are confident in your abilities. I mean, there will be some providers who will be confident, but the vast majority will not be. So in private practice, mostly the vast majority of people are on the specialist register. So I wouldn't say it's impossible, but it's very unlikely. Theoretically possible, but very unlikely. Also, there are guidelines from the college which say that you have to be on the specialist register to do certain kind of surgeries.
Maybe refractive surgeries.
Yeah, refractive surgeries. You have to be on the specialist register and also do cert LRS to do refractive surgeries in the UK. This is the college guideline. It's not legally binding, but it's a college guideline. It's not a GMC guideline.
Right. Okay. Fine. Another question for you is courses. Let's talk about courses. Do you have any specific courses in mind that you had to do? Do you think some courses are essential to get your portfolio pathway accepted?
Yes, there are 3 courses which are essential. One is training the trainer. The other one would be management in the NHS, and the third would be good medical practice. So these 3 have to be. You have to tick these 3 boxes. They are essential. Now, mind you, all this I'm saying, all my advice is for the 2016 curriculum. It's not for the 2024 curriculum. I'm not well versed with it. I know bits and pieces of it, but I'm not well versed with the 24 curriculum.
Yes, because that's the argument. So the new curriculum is more flexible. But still, I don't know. I mean, I'm not sure about others, but I find it confusing. It's new. The forms are new. 14 fish. People are still struggling with it. So
I would advise people to stay away from that thing.
Yeah.
Use your paper forms. I mean, it's just a paper, and what's the big difference? You just have to. You'll forget writing after some time if you don't do any writing.
Yes. Yeah. But the issue is bunching. So again, people have got now a deadline of maybe a year or so. How would they be able to find the time to squeeze all of the evidence in that year? It won't be easy.
It won't be easy.
Yeah. I've told them as well that there is an option of just accepting the fact that you will have your application rejected from first go if you haven't got everything, but that will take time. So theoretically speaking, June 26th, let's say June 26th is your deadline. So you submit and you know that you've got 100 cataracts left. until the GMC replies back and the college and all that sort of thing, that's at least 9 months or a year after that.
Yeah.
So that's June 27.
Yeah.
And they will come back saying, oh, unfortunately, blah, blah, blah. You've got these recommendations. Now you've got another year to submit your extra evidence. That's June 28, roughly. So
Yeah.
there's still some time.
Yeah.
That's something people might not notice much or are not aware of. So you do still have time, but you will have your application rejected to start with.
Yes.
And then you can submit more evidence as you go along.
Yeah. Yeah. That is one way out if you want to think about it that way.
Yeah.
But then that's only for people who are starting out now. I mean, next year this advice won't hold good.
Exactly.
And next year there's not enough time to submit. So
exactly. And again, some people have got the misconception of, oh, my application is not ready. It will be rejected from the GMC. There's nothing like that. So they will have to accept it. Okay. I think the only criteria is you have to have a primary medical qualification and 6 months of training, I think, in ophthalmology. And that's it. There is no other essential criteria. So you are allowed to submit. They will come back to you saying, however, you've missed the oculoplastics rotation. Are you sure you want to submit? We advise you to submit more evidence on that, or more audits, or more cataracts, whatever.
Yeah, your GMC advisor would tell you that.
Yeah, that's the advice, but it's not, you don't have to follow their advice, because they will give you a deadline of a month or two to submit some more evidence, and that's it. They're going to send it to the college. So it's advisable to listen to what they say. They're very experienced, but you don't have to. So at that point, you just have to accept that your application is missing, and I'm sure the college will get lots of let's say, not full applications within the next sort of year, because people want to submit anything they've got before the deadline. So that's what I'm expecting to happen. Do you agree?
Yeah, I agree. I perfectly agree.
Yeah. Should I take a few questions? I think that's the main thing. So Asam Mahbub is if I have all the right experience from outside the UK and complete all requirements, do you think the application will be accepted? What do you think?
Absolutely. The reason the portfolio pathway exists is they want to accept evidence from abroad. That is the main reason the portfolio pathway exists.
Yes.
So if somebody tells you that evidence from abroad will not be accepted, that is false. And if an assessor or if somebody rejects your application just because it was from abroad, when you have fulfilled all the requirements, you can appeal it. I'm pretty sure you'll get through.
Yes. It's definitely accepted, I'm sure. However, obviously, there's always a question of how would they believe my evidence? My evidence is by somewhere in Egypt or in India or wherever, and my verifier is someone who's not in the GMC register. How can I prove that my evidence is true? That's where people sort of get, confused. And it's still a big question mark. Would the assessor be convinced that you've actually done all these things? Would the verifier be able to prove that, yes, his evidence is true? That's why people are a bit sort of afraid of submitting all their evidence from overseas.
So I haven't done an assessor course as yet. I have not undergone the college assessor training. So I don't know exactly how the assessors look at the application, but I would imagine they have to follow the letter of the law prescribed by GMC. Yep. Now, why would someone believe a consultant who acts as a verifier in the UK and not believe a consultant who acts as a verifier elsewhere?
A very good question.
So that premise is fundamentally racist, I think, in my opinion. Just because somebody's from a different country, that you're not going to believe their evidence. So why would you believe the evidence submitted by someone in the UK?
Yeah,
I don't get it. So if you follow the actual guidance provided by the GMC, it is very clear that evidence, it doesn't matter whether it's in the UK or outside the UK, if it's submitted in the prescribed format and follows all the rules, then there is no leeway for the assessor to believe the evidence or not believe the evidence. Assessors, I don't think, sit there and they're not making moral judgments. They are looking at the evidence, and I think it would be accepted. If it is not, in some cases, obviously you can appeal it. I mean, the rule of law is something that UK holds in high esteem. So it can be appealed. So I wouldn't tell people just because their evidence is from abroad, don't submit it. No. If you have the evidence in the right format, and if it is according to the SSG, then sure, why not? Go ahead and submit it. In fact, there have been a few cases where people have gotten, even in the olden times when things were much tougher than what it is now. There are cases of people who have got accepted into the specialist register just with evidence abroad.
Overseas, yeah. A very good question. I mean, why would you believe evidence in the UK, not from overseas? It just doesn't make sense. So I think I totally agree with you. Just that people have got lots of doubts. You know, they think, is that it? You know, so all I need is just submit a log of all the cases that I've seen, and would they believe me? Actually, the answer is yes. You know, and again, remember, again, that's a very good question. So let's say something like rupture globes. Yeah. So now you need at least 2 rupture globes. Yeah. Let's say you fake 2 rupture globes. Yeah. You haven't done them. You've just faked a OSAT, and you've got your friend, colleague to sign it or whatever. But then you're on the register, and now you're entering a consultant post. What are you going to do if you've got actually a rupture globe?
Rupture globe, yeah. So that would be the most foolish thing to do.
Yeah.
I mean, you are setting up yourself up for huge trouble.
Yes.
Even jail, I would guess.
Yeah. So you shouldn't lie. Yeah. You shouldn't fake your evidence. You need to be trained. You need to cover things that are really necessary. So in the UK, maybe unlike anywhere else where you're doing just private work and you send all the weird stuff to the university hospital or whatever, in the UK, you are going to be on call. You are expected to cover all emergency cases, general ophthalmology. You need to be a very good clinician. You need to see all sorts of broad experience in all subspecialties, and obviously surgeries. If you just mention on the application that you can do squints and you haven't done a single one, what if you obviously you have an urgent squint, but again in ruptures, we just want to remove the muscle and hook it back in or something and suture it back. If you can't do that, then how would you manage? And questions will be raised. So I would really advise people to actually train. Yeah, so you need to be trained, because NHS jobs are not easy. Consultant jobs, you've got lots of responsibility and lots of people to train as well. It's not just on you on your own, you know. Fine. Someone is asking.
Before you submit your application, you should ask yourself, am I ready to be a consultant? That's the first question you should be asking. Yes. And then the question is asked to the assessor, please let me be a consultant. You ask yourself whether you're ready first before you submit it.
Yeah, I agree. Do we need validated logbooks for surgical and laser procedures, or can I download it from the college e-logbook?
Well, the validation of logbook is done by the verifier. You don't need any countersign or anything. Yeah. Whatever surgeries you have done, you submit the logbook in the prescribed format, and then your verifier does the verification for it. So
yeah. So some people are not aware of the verifier performance. You just need a verifier performer, and that's the only thing that needs to be signed, actually. Obviously, now the forms are on paper, so yes, you need them to sign it. But if you are using it electronically or whatever, maybe 14 fish, that's not signed, you know, it's just electronic. So the only thing is the verifier performer. Have you struggled with your verifiers? I mean, did they give you a hard time to sign things? And
I had the very good fortune of having very good verifiers. I had a very supportive team around me. Good. And I was doing the service provision for them. So, I mean, it is also in their interest that I become a consultant. So they were very supportive.
That's good. And your referees, again, people are asking what does actually a referee need to sign, or what's that form, the structured report. My understanding is that it's very detailed and it's like 10 pages worth or something, and they ask very specific questions. Do you agree?
Yeah, so the structured report is actually a very, very important piece of evidence, at least in the new in the portfolio pathway 2016 curriculum. It is an extremely important document. It can cover a number of your learning outcomes. Yeah, just that structured report can cover a lot of your learning outcomes. So it is important that you choose a verifier very carefully, and you have a word with your verifier as well, that it is not something that you lightly sign and leave many columns empty. That report carries a lot of weight. So I personally had good verifiers and good referees. Sorry, referees. I meant referees, not verifiers.
Yeah, because they ask. Yeah, they ask. Tell us, tell us an example of when Prashob has showed good communication skills, for example. So they have to have worked with you, because if they're, they're the lead and you haven't worked with them before or whatever, they will write down something, cannot comment, or NA, or I don't know, I haven't worked with them. Useless. Yeah, so you need someone who can actually say good things about you, and someone who likes you. Yeah, so because as Prashob was saying, that they will look into those comments, they will look at the comments of others that speak about you. So whether it's the structured report, or if it's the clinical supervisor report, or your appraiser, for example, anyone who's mentioned comments, they will get into that, in detail. And they, I'm sure you've had the same in your outcome form. So, okay, congratulations, you've got this and this. They would say, we're convinced that Prashob can do this because Mr. X
so and so said so and so.
Yeah. So very important. Very important. Fine. Has anyone got any other questions they want to ask? 20 clinics. Let's talk about it. Okay, so I'm sure I can expect what the question is. 20 clinics per subspecialty essential, or could we use cases from general clinic and eye casualty instead?
You can. The short answer is you can use cases from any clinics. The 20 clinic thing is no longer there. That said, I told you I was paranoid. So I was given some advice by older candidates that this 20 clinic is something that is set in stone. So I actually did the 20 clinics, except for neuro-ophthalmology. I did more than 120 cases of neuro-ophthalmology from casualties and elsewhere. You easily get those cases. But I don't think it's required. 20 clinics thing is a thing of the past. What you're required to show is, as mentioned before, as I keep telling in the group, you have to show that you have the knowledge, skills, and across the depth and breadth of the curriculum. So basically, to give you an example, if for glaucoma, you have to have seen neovascular glaucoma, you have to see primary open angle closure, a few of the traumatic glaucomas, angle recession, the some secondary glaucomas. So if you have evidence that you've seen all these cases and manage them accordingly, then I think the assessors would be convinced that you have the knowledge, the depth and breadth of knowledge to manage glaucoma. That's what you have to show. You don't have to actually sit and compile list of 20 clinics. That's no longer required.
Because I don't care if you've seen 50 cases of dry AMD and I just observed, so useless. So it's better just maybe 5 dry AMDs, and then maybe each one has got a different scenario. So one you've done a CVI form, maybe another one you've requested fluorescein for, or so different management, different scenarios. That's what they're looking for. And I'm sure the assessor will not go through all details. They don't have the time. But if they have a quick scan through and they think that you've covered most things, then that will work. And how about you've submitted case logbooks?
Yes.
And roughly at least 100 cases you've used.
Well, I submitted more than 120. I actually had to cut down because my page count went way about 2,000, so I had to cut down a lot of the cases.
Okay.
And I carefully selected only the cases which showed that variety.
Right.
But it's not necessary to submit so many cases. At least speaking to many other candidates, you need to show solid volume of cases where you've shown that you've covered the depth and the breadth of the specialty. That's what's required.
And how about the outcomes? So the learning outcomes, 160 or 170. Did you make sure that you've covered each one twice?
So I did not follow the 180 outcomes Excel sheet. What I followed was the green and red and yellow. I mean, green and red, no yellow. The green and red Excel sheet for the learning outcomes. So that is, even when I submitted an index of learning outcomes, I also submitted an index to make it easier for the assessors. So I just made the copy of that Excel sheet, and I also added another column where I specified which file, which page, and which institution I have done that. I have submitted the evidence for that particular learning outcome. So I followed the red and yellow I mean,
Yeah,
read
but I
and
mean,
seen.
each outcome, was it 2 or only one piece of evidence?
So two is required. Two pieces of evidence are required. Some cases, even one may be enough. In certain outcomes, I guess, certain low-level outcomes, green ones,
Yes.
even one may be required. But to make your application watertight, submit 2 per each outcome. That would be the best thing to do.
Yeah, especially the ones that they like specific forms for. Like, for example, ultrasound. It's not enough to submit 2 CBDs of ultrasound or I've ticked off the DOPS instead. You still need 2 DOPS. Yeah, because that's the practical. Again, ultrasound, you'll find it twice. So once in the PI, which is the theoretical side of ultrasound, and that could be ticked off by a CBD or a course you've attended or something. But the this practical skill bit, which is PS 18 or something like that, that's the DOPS. You need 2 DOPS because, and it doesn't make sense if I agree with everyone that I'm a VR consultant. I do this all the time. I give courses and I've submitted feedback about that course and did not need to do 2 DOPS. It will be rejected. They still like their forms. Yeah. So that's the, if all of this is about the old curriculum. Okay. So we're talking about the old one, not the new portfolio pathway. The new one, we don't know. So if you ask us any specific questions, we don't know. Maybe the college doesn't know. Who knows?
Yeah.
How many CBDs did you submit for each specialty?
I didn't count, to be fair. I did not. That doesn't matter. There is no assessor is counting the number of CBDs for subspecialty. I submitted what is required.
Okay.
What is required in the learning outcome Excel sheet, I've submitted. Now,
Right.
if you count it and tell me the number, I've submitted that number. So I actually didn't count it per subspecialty. I don't know.
Fine. For me, it was some specialties at least 5, like maybe uveitis. Maximum was about 10. Yeah, so I don't think you need more than that. That's too much. But do not submit 1. I think 1 is too few. So just maybe submit a few.
If you look at the if you fulfill all the tick all the boxes in the learning outcome Excel sheet, you will have the required number. I don't think you have to count the number of CBDs you submitted or number of DOPS you submitted per subspecialty.
Yeah.
Nobody's looking at that.
Right. In portfolio SSG, do we need case logbook? Let's say someone, I believe that the logbooks take the most time, because you're going to the system looking for the case. I've repeated this before. It's a boring case. Let's look at another one. Lots of wasted time. Do you think there's any other options other than case logbooks?
I really don't know. It was case logbooks that I did.
Yeah.
Case logbooks, you can call it different things. Case histories.
Yeah.
So I over submitted. I told you earlier. So I submitted this 120 plus case logbooks per subspecialty. I also did this 20 cases, selected cases which are interesting or which had some extra management things within it. So 20 cases per subspecialty, I submitted a detailed kind of case logbook, case history book. I don't think you need to submit both. I think 1 should be enough. If you have a detailed book of around 20 to 30 cases, which demonstrate the whole breadth and depth of the specialty, it might be enough. I can't say for sure, but because I'm not an assessor myself, I'm not seeing this thing.
Yeah.
But it might be enough. That is the sense that I'm getting with.
Because someone with was it Pratik? I can't remember. He mentioned was not Pratik. Was it Bilal? Can't remember. Someone mentioned that he did not submit any case logbook. Yeah, he just used patient letters.
Okay.
But in the other sort of side, you have to submit many patient letters to cover everything, and has to be detailed letters, like saying very specific details. I've done a fluorescein angiography and it showed in the arterial phase this or that. So you need to submit very detailed stuff. So the assessor is convinced that you've covered everything, about the case or that. Yeah.
If you have those patient letters, then I think what is stopping you from making a case logbook? It's just you have to sit in front of a computer and copy the thing down, right? So
more or less, I agree.
So if you have the patient letters, you have the case logbook.
Yeah, it makes sense. A case history is another option. I mean, people call them a bit different, but a case history is basically history. So it's a very detailed, it's like a CBD in written form. So rather than case logbook is tiny, sort of a few words about each case. You need case history. That's another option. Presentation, medical history, ocular history, allergies, examination, findings, treatment, everything about maybe 1 page worth or 2 page worth about that case. So that might be an alternative, and it might be actually quicker. If I go back in time, I would have actually used case histories rather than case logbooks.
That's a good idea. That's a good idea.
Yeah, I think that would work as well. So you can mix and match as well. So I think there's lots of flexibility. But that's a good thing about CESR. There's lots of things you can do. Fine. Has anyone got any other questions? I haven't got specific questions in my mind. I think I've asked most of what I want to ask. Prashob, do you want to add anything? What would you advise people going to CESR? Let's advise people 2 scenarios. Yeah, one who hasn't started anything yet. Okay, who's still doing their exams. They failed their part 1. They're sort of hating everything in their life, and someone else who's about to submit very soon. Yeah. So, what sort of advice would you give each?
So, if you haven't started the journey at all, you have to ask yourself: will you be able to submit by July 26? That is a big question. I mean, don't just look at your own abilities. You might be a super hardworking, efficient, risk-taking, or extremely stress insulated person. Ask also whether you have the support for it. Support. Many people mistake support to be trust, which ask you to actually hold your hand and take you to clinics. Nobody is going to do that. Support basically means you take your free time and you attend those clinics. The trust lets you do it.
That's the support. Yeah,
that's what you mean by support. It really does not mean that somebody is going to actually handhold you to do all these things. So see these 2 things. See if you have all the subspecialties in your trust, or if you will be able to go to another trust and do the things which you are deficient within that time. And that is not an assessment which I can make. It's only you can make that assessment. If you can submit by July 26, then get on it. Get on the accelerator. That is one advice. If you are not in that band, then prepare for the 26 curriculum. If you have enough cataracts, of course, you can go for any of the subspecialties. If you don't, then I would advise to go for some of the other subspecialties, non-surgical subspecialties, other than cataract, cornea, and VR. And of course, you can. I don't think anybody will stop you from being a consultant in cornea just because you or CESR you submitted only these level 4 outcomes. If you are actually confident in doing cornea, and if you actually have been doing those things before, I think you will be accepted. Nobody's looking at what level 4 outcomes you submitted in your CESR application.
Exactly. It's all about the interview, about what you can do basically to serve the job.
So that would be a way out. Of course, things can change. They might take the numbers away. Some miracle might happen.
I'm honestly, I'm going to clap for Shweta if that happens, because I'll be very impressed. My understanding is that things, even if we succeed in doing something, it will take years. That's my experience. Again, I don't know. Who knows?
I wouldn't bank on it. I wouldn't bank on the numbers being taken away.
Yes.
I would take things as they are. I'm kind of a little pessimist, so worst case scenario guy.
Yeah.
So always look at the worst case scenario and plan accordingly. And if you're already about to submit, I mean, you got in the second scenario that you mentioned, you already have all the evidence. Step on it, get it submitted before July 26. It's a straightforward no-brainer, easy choice. You don't have to go for the 24 curriculum. Submit in the 2016 curriculum before July 26.
Yeah, and there is time. There is time, at least a year. So there is enough time. Yeah. Fine. I think that's an hour. So thank you very much, Prashob. That's been very helpful, as usual. Thank you very much. And this will be put on YouTube, if you don't mind, Prashob. So for everyone can access it later. And I think Prashob is very famous on the group. So if you've got any questions, I'm sure he wouldn't mind. And I think hopefully, who were the other 2 who got their Ritika, her name is, and Bilal.
Ritika got it.
Yeah, and Bilal as well. So these are the 2 more recent people who got their application accepted. So hopefully we'll get in touch with them very soon, and we'll do 2 more sessions, I hope. Okay.
Yeah.
Thanks, Prashob, again,
Thank you.
and congratulations.
Thank you.
Well done.
Thank you very much.
Thanks, guys. We'll speak soon. Bye.